What differential diagnoses should always be on your radar in the context of hamstring strains, and which subjective and objective signs really matter, and which ones don't? Today on Physio Discussed, we're unpacking hamstring injuries with two world-class clinicians working at the very top of professional sport and applied research. Scott Hulm is a highly skilled sports physiotherapist with a strong interest in injury prevention, rehab, and athletic performance. Adam Johnson is a physiotherapist currently working full-time at the Everton Football Club in England. Adam has been heavily involved in short to medium-term rehabilitation of muscle and ligament injuries. You're going to absolutely love today's episode. It's filled with plenty of clinical gems. I'm Sarah Yule, and this is Physio Discussed. Well, welcome Adam and welcome Scott to the podcast today.
Thank you very much. Thanks for having us.
It's great to have you both talking all things hamstring injury and hamstring strains. So I think it's right that we start at the very beginning and just going to clinical practice. So I'm curious, in your clinical practice, how do you both go about diagnosing a hamstring injury or a hamstring strain? Perhaps Adam, we'll start with you.
Yeah, I think obviously within the elite sports setting, there's generally quite a lot of pressure to kind of make that diagnosis quite early. And we would be lucky enough that we would kind of see a lot of the mechanisms and be able to go and refer back to them. So we would generally get that kind of early picture of a mechanism of injury, whether it's an acceleration, a maximal sprint, there's any curve running involved, those sort of things. Again, generally we'll be able to get the video footage, so we'll be able to review it. And then on the bed, really, it's about getting those early signs, kind of, is there any loss of range, any loss of strength? And then again, I think if you look at the literature, and a lot of it would suggest it's probably quite relatively easy to pick up if someone's got a hamstring strain, where the difficulty comes is trying to figure out how big and significant that injury is and exactly what structures are involved. So I think, again, with the pressures that are involved, we would generally look to utilise MRI imaging relatively quickly within our practice to support what we're seeing in our objective findings and give confidence in that diagnosis, and then be able to kind of give a prognosis off that. So a lot of our decisions will be, as I said, relatively acute. We'll see that person quite early on when they're still probably quite symptomatic, and then lead them down that path of utilising the correct imaging processes.
And just in terms of, obviously, mechanism of injury is very relevant, and you've got the luxury of video playback. How much weight are you putting on mechanism of injury and immediate symptoms versus what you might find objectively?
Yeah, I think, again, if we're always going to have warning signs, if we kind of say it's a game and someone's gone for a maximal sprint and they go down and they're unable to continue, that's going to be one of our kind of key signs that would lead us there. I think, again, where it becomes maybe challenging is those cases who present to you in the treatment room with those kind of low-level symptoms that have kind of maybe progressed over a couple of days. And again, I think there's some recent stuff come out from the guys at British Athletics to suggest that they're the real warning signs. And are they structural injuries? Are they kind of precursors to structural injuries? And what can we do about that? So I think, again, reading that paper in the last couple of weeks has really resonated with me in terms of, just because someone's functional and maybe assesses well and objectively looks okay, really listening to that subjective that they're giving you, to understand and kind of pick up that clinical picture as early as possible to try and see what might contribute further down the line. So trying to take everything in subjectively as well as objectively to give you that picture and really flag up those lower level injuries if you can, before they progress to anything more significant.
Yeah, great. So you're getting the whole picture. And Scott, what are your thoughts?
Adam summed up pretty well. I think definitely in our elite sporting world, it is fortunate to have the video footage, and I think sometimes linking that, certainly in terms of location of injury, seems to be a really crucial piece of the puzzle. I think now we're starting to have a better understanding of probably the structural locations and some of these tricky sites. So it's definitely sort of add to the clinical assessment is those palpatory, locations, particularly, for instance, if I'm seeing a particularly high grade sprinting mechanism with sort of internal tibial rotation, and we're seeing that distal side as the side of injury and palpatory soreness. Now I've already got a pretty high degree of concern for sort of that distal aponeurosis and these T-junction type injuries, and alternatively, those high sort of long length eccentric sort of actions, maybe with a level of hip abduction, the high grade proximal semi-mem sort of avulsion injury. So like just trying to place those sort of mechanistic elements with some of the clinical features, particularly in terms of location, I think sort of is something that certainly jumps out at me, which then certainly helps guide our imaging process from there to exactly identify sort of the level I guess of injury from a severity point of view, kind of the tissue involved, in terms of are we looking at a free tendon type injury, either from an avulsion or a rupture point of view, or are we starting to look at some of these aponeurotic injuries, intramuscular, or this distal aponeurosis involving the T-junction. So just trying to place those together. But I think Adam's point around sort of these acute on chronic type injuries, we don't tend to often sort of categorize them in that manner, but certainly in our fields, I think where the training demands can be so high and match congestion at times, depending sort of certainly on the sporting pursuit, trying to navigate where our athletes may be starting to show signs of I guess overload or fatigue or at a subcellular level of failure, and then as a result, can we sort of look to identify those low grade type injuries? And there's a great scope of these that diagnosing is sort of is obviously our primary sort of role in these acute instances, but can we strategize our way to sort of prevent some of the more high severe sort of the high grades of particularly severe type injuries.
I suppose I was going to dive into that classification component a little later on, but how do you go about classifying those hamstring strains in your practice? And what are your thoughts in terms of, as clinicians, how specific do you think we should get prior to sending for MRIs and imaging?
I might kick off with that. I mean, I'm probably biased in this space with sort of my interest in around sort of the aponeurotic sort of involvement. In sort of my practice, obviously similar to Adam, we utilize MRI pretty readily, and as a result, that sort of certainly helps to guide us along the BAMIC, so the British Athletics classification system, and certainly that helps to, I think, start to build out what sort of tissue type we're certainly the level of the lesion sort of is occurring in as I was sort of alluding to. I think our understanding around probably exploring that in a little bit more detail is probably necessary now. In sort of our practice, we tend to use a little bit more a dynamic ultrasound approach, particularly maybe at that distal aponeurotic site. MRI tends to undersell maybe the severity of those injuries, and we've certainly had instances where MRI would suggest a lower level injury, where we were concerned about sort of the level of that severity based on some of the findings from the MRI. We went to dynamic ultrasound. We went to a surgical approach, and and arthroscopically or from a surgical perspective, that the severity was certainly more extensive. So we know that there's still limitations to some of these things to trying to build out the whole picture. But I tend to sort of blend, I guess, a BAMIC approach with certainly some of the work that's done, certainly from Barcelona and Carlos Pedre and certainly his work through the use of sort of alternative imaging approaches to try and classify sort of the level and type of maybe tenderness or aponeurotic injury.
Yeah, fantastic.
Yeah, and I think just to agree with that as well, the similar thing, and we would utilise the BAMIC classification as well to get those gradings. And I think over the years there's been much more understanding of what that means, not just within the kind of medical space, but our players would be very conscious and aware of what those gradings are, that they kind of have an understanding of that, which is a positive and a negative. It helps with explaining. That'll be the first question they ask when the report comes back. Well, what grade is it? Is it a C? Because they know that means significantly longer rehab time, and anything when they hear those kind of 3-4 Cs, and they understand the implications of that around time loss. Where it's also then the negative is that's a really big band to just put people in. Not all 3 Cs are going to be the same, as Scott's kind of touched on. The location of it has a massive implication, and also again around some of Scott's work, even just the direction of the tear. Is it longitudinal, transverse? There's so many different bits that are going into it that I think we're trying to understand more on. Again, within this elite sports setting, you're always trying to minimize time loss and kind of trim as much time as you can, but with that comes knowing the ones that you also can't push, and you have to respect that those tissue healing times. So I think that's definitely useful. And I think again we would look to utilize dynamic ultrasound. I think the issues with that is it's a lot more user dependent and kind of open to misinterpretation or missing things, whereas that MRI is a little bit more consistent now that the BAMIC classification's been used so consistently for so long. We have a little bit more confidence in that. I think as kind of staff and players and a group, we understand what that means. So it'd be very similar to what Scott said, just to build on those points a little bit.
Yeah, I just want to jump in. I see Adam's point there around the player involvement and even educating other staff around that. As soon as the tendon or the aponeurosis involved, everyone is completely aware within the 4 walls of the organisation, and so to try and educate on not all tendinous injuries are the same, and not all are going to have to miss extensive times, and the bias that obviously that we have to navigate as clinicians, I think is certainly something to be cognizant of, and no doubt we'll talk to some of the clinical and features and criterion based approaches where it is a real blending of these skill sets and knowledge base, because I think just to suggest that we have this level of injury at particularly maybe like a tendinous site indicates this level of time miss, is probably underselling sort of the interpretation around sort of trying to pull a multitude of clinical, as we've alluded to, subjective, objective features there, and all that imaging data all together to sort of at least put a framework around when we're returning this athlete to play.
It's, and no doubt this is probably a larger question here, but Adam, you also spoke before about there's a decision process of who you might push versus who you might take a more conservative approach. And Scott, as you've mentioned, not all tendon injuries are created equal. What's your decision process in terms of who you do push and who you don't? And then how do you navigate that conversation with the players or with the patients?
Yeah, so I think it's a real challenge, and kind of had some recent conversations around these, not just with hamstrings, but it might be ankles or whatever. And it's about understanding the player and their demands. And I think if your conversation around a 35-year-old centre back in football who has been around the game, understands their demands, understands how to manage themselves, and won't be exposed to huge volumes of high-speed running, will very rarely hit sprint distance, maybe in the tactical setup that you're in, versus your 19-year-old star striker who is going to be achieving repeated maximal velocity output, high sprint distance, and that utilizing that as their game. Those decisions have to look very different, and kind of what your level of kind of acceptance of risk has to be very different. And again, all those things like timings in the season, what are you looking at? If this is someone who is in pre-season and has the whole season ahead of them, the chances are you're going to be a little bit more cautious around that to try and minimise the risk of re-injury and have them fully fit throughout the whole season, versus someone who, again, is looking end of season, cup final, etc. All those scenarios that we talk about are the things that come into play. And again, I think that's where some of the subjective comes in around players' appetite for risk as such, or appetite for being aggressive around, again, previous experiences. This will look very different for someone who has had 2-3 hamstring injuries in the last 18 months versus someone that is, again, halfway through their career, 26, 27, never had this before. And again, you're thinking, okay, this might be due to external factors, and if we can manage those a little bit better, we can manage them through, versus someone who has got a kind of chronic injury history, and you need time to really address that and make those changes and get them in the best place to minimise re-injury risk. So I think that's a lot of the conversations that we would be having with the management, with the player, with us as a medical department is, okay, what's contributed to this, and what do we think is a successful outcome for this player? And again, as kind of Scott's has touched on, not just looking at it as this is a 3C or a 2B, it'll be 6 weeks or 12 weeks. It's okay, who's the player in front of us? What's led them to this? And again, have they had neural symptoms in the lead up to it? Has there been factors that we need to work on? Has there been issues with muscle soreness before? Or is this just a one-off incident that we understand why we think that's come about?
Sorry, Sarah, I'll jump in there as well.
Please do.
Yeah, look, I think that Adam's point's brilliant. I mean, in terms of the athlete in front of you, and obviously the injury history and the demands of the game, and the demands of that particular player is absolutely first and foremost. I think how do we look to get this athlete back to those peak demands? And obviously that looks a little different for everyone. But I do still come back to just some of the pieces around, okay, what type of lesion are we dealing with there? I still think that plays a role here. And there's certainly, aspects of tissue healing and a respect of elements that in terms of the type of lesion that would influence, when I might push and pull. And that certainly that would look very different for very different types of lesions. And, again, locations may play a role with that. And then that's then starting to drive, what are some of the other features that this athlete's shown me before, in terms of that might be muscle architecture, some of their clinical strength outputs, where have they been particularly poor, where are they strong, what else have we been able to explore with them? We might even have a little bit more about, from a morphology point of view, what they look like, and does that play into some of their risk profile? But just to add to, I guess, Adam's overall point is it's all about building this risk profile and then providing key stakeholders. This is sort of the cumulative effect of all these pieces, and this is what we are sort of proposing. And then as a result, particularly as a medical and a high performance team, we make decisions based on that, and sort of go to work in the rehab space.
I think you've both summarized that marvelously, and it sounds like, as it never usually is, a yes or no and a straightforward answer, but drives home the importance of understanding that full patient profile and making a patient-led decision based on the evidence that you have in front of you. So I'm curious now, let's zoom in a little bit more on what you're actually seeing and hearing in the room. And at some point, Scott, I'd love to hear your thoughts on how you actually explain the physiology in terms of those tendon injuries versus the muscle injuries, because as we know, the education that we give to the patient can often reinforce the adherence to the treatment as well. Well, actually, I might ask that question now.
Sure. Yeah, go for it. It's a really great one. I mean, to be honest, there's nothing better than a great diagram and visual representation for athletes. So generally, that's kind of where I tend to lead a lot of those questions in terms of we'll often utilize the MRI. And then I'll tend to illustrate that in terms of a more sort of muscle tendon schematic, and trying to explain to athlete kind of where their lesion or injury is, and then provide some context around, for instance, if it is that T-junction side, I'll sort of illustrate, why we suspect, particularly if we're seeing a splitting type lesion, where we see an extension of kind of the T-junction, like protrusion along the epimysial border, that might be something that we would, suggest is a little bit more concerning, and therefore explain, why we might take a little bit longer in the early stages, before, for instance, these athletes know a lot about their training demands, why I might take them into sort of some longer length, either testing or training positions early, why I might protect some of that MTU length. So kind of, again, just using that visual representation and kind of connecting that with things that they know around, as I said, exercise or testing procedures that we would often do, and as a result, the athlete is completely aware of. So kind of connecting those types of things really kind of as simply as possible.
Yeah, fantastic. Thank you. Do you have anything to add there, Adam?
Yeah, I think, again, just building on that, I totally agree. I think they work, like the imagery around it works really nicely. So again, just those kind of different examples around if someone's got a big intramuscular tendon injury and there's some loss of tension in that tendon, just that ability to explain and demonstrate that to the patient, the player, to show, okay, let's compare this side to the injured side, and we can see that loss of tension, that waviness, and that understanding that, okay, that tendon isn't going to be able to provide the scaffolding and the elasticity that you need it to provide, and this is what we're trying to work towards, and utilizing those re-imaging periods throughout the process to show how that's progressing and continue to try and gain that ongoing buy-in to the rehabilitation, to be able to show, okay, this is where it started, this is what you had originally, this is how we're progressing through, and this is how you're adapting to the work and the loading that we're giving you in hopefully a positive way, again, to give confidence that, okay, I've seen that before and I can see how that's progressing, and I can see how that's going to allow me to function again within my return to sport. And again, as you go into those criteria-based approach through to high-speed running, sprint distance, max velocity exposures, trying to provide them the confidence from the real obvious imagery and understanding of what they've involved to guide them through that process. So I definitely think imagery is a really good way. Obviously, one of the skills is to try and be able to explain it to everybody. You have to be able to explain the same injury to the medical team, to the manager, to the player, to the agent, all those different kind of stakeholders within the process. But images and diagrams help with that to kind of level the playing field, so everyone's kind of seeing and understanding hopefully the same information.
Yeah, absolutely. Understanding the how and the why, and then set the expectations. I'm curious, before we move on to the next question, do either of you have any regular analogies that you use or usual descriptions you roll off?
My athletes would just say that I always bring out my three-dimensional computational models. I
There
think I
you
have
go.
these sort of fancy biceps fem and long head and short head, and I'm showing them, and I'm sure they're more sick of seeing them than anything. But that's generally, yeah, more than a good analogy. But yeah, I'm just I like to jump in and give them a bit of a demonstration.
Yeah, great. What about you, Adam?
I think, yeah, not. I think a lot of mine would be kind of around like yeah, what are the demands of it? So again,
Mm.
like really driving home what that tendon is going to have to do. For example, is it nice and elastic? Is it kind of compliant with what we need it to do? Kind of trying to break down. So using those kind of keywords rather than anything else, and then leading that through into the rehab exercises and go, okay, we're doing this because we want to change the elasticity of this structure, or because we want to provide load to this certain area, and just trying to keep using keywords so they kind of see the point of everything that they're doing, and not kind of going too kind of maybe in depth with every single exercise. But today is a day focused around this, or this morning we're going to really focus around X kind of keywords, and try to utilize that and give themes to everything that we're doing. So it'd be more those kind of rehab based themes throughout the process that hopefully they would see and not get bored with, but kind of understand constantly what we're trying to achieve, and see the continuity and progression throughout the process.
Yeah, Adam, the elastic band model, I think, is like such a nice one for athletes to sort of grasp from a tender's point. Isn't it? Like we'll often use that in terms of snipping the TheraBand in certain ways to sort of demonstrate kind of like how the lesion might be presenting. Again, the longitudinal kind of split along the intramuscular tendon is such a nice example of why, if you keep loading that structure, it's just going to keep peeling apart. So hence why, again, when you lay that onto the rehab themes of why you're doing X, Y, Z, I think, yeah, that's such a nice way of, I think, for athletes to really grasp that. And my argument is that they're probably largely, these are all connective tissue lesions. I think the idea of like this isolated muscle injury is probably a little of an outdated model. You effectively are you are going to fail at some point of sort of that connective continuum. So explaining to the athlete that elastic band kind of theory is probably preferable, in terms of trying to explain too much more outside of that.
That's great. It's the ultimate challenge for us as clinicians, isn't it? It's how do we make the complex simple without losing the integrity of what we actually need to say. And I know that often that comes with both of you probably explaining the same thing in 1,000 different ways, and having a feel of what lands and what doesn't land, and so refining it over time. It's our never-ending journey. So let's dive in a little bit more. Going to the subjective side, you've already mentioned mechanism of injury. What other things might you listen to in the patient's story that will influence what you then go on to measure objectively, or what might influence your prognosis? I know that's a large question, but Adam, we might go to you first.
Yeah, so I think one of the key things, again, within the literature, and it's a really difficult one, is that kind of link between maybe some low back pain or neural sort of symptoms. And I think, again, where the research not is lacking, but where it's very difficult to research this sort of area, is to kind of prospectively understand that. It's difficult to kind of get a big sporting cohort where, I don't know, you're assessing slump test every day, or at least weekly, to try and understand, is that a risk factor? Because we know that it's something that's there post-injury. We see it, whether that's where the bleeding or scarring post-injury around the nerve. But has that led to it before? Is there something kind of further up that chain or along that chain neurally that's contributed to it. So that's definitely something that I would always be asking and trying to understand from a subjective point of view. What have you felt anything in the lead up to this? Because we're likely to see, as I say, positive slumps or straight leg raises with hip internal rotation afterwards. We're likely to see some of those neural signs after. Is that a symptom of the injury that they've sustained, or is that a predisposing factor that we need to consider within our rehabilitation and trying to address that again in those patients we might see with recurrent injuries? This is definitely something that I'm looking to consider, and what can we do to try and probably dampen down that kind of neural sensitivity we're maybe seeing as part of the rehab process again. So that's a really key subjective questioning line that I would always go down, because I think you don't want to just assume that that's come about because of the injury, and then you're addressing all the other structural things, respecting all the kind of healing processes and the timelines that come with that. But actually the main thing that was there prior to it you haven't addressed, and then you're always kind of heightening that risk of re-injury further down the line. So yeah, for me that kind of neural component, or how that's referred, or kind of low back pain, and what's going on at a disc level within the lumbar spine, what kind of structural components are there that might kind of increase the risk of re-injury or reduce the risk of a successful rehabilitation process. So yeah, definitely that for me.
Right.
Yeah, for me, it made me think of some of Matt Wallen's great work sort of in injury prevention space, which is really around touch points and sort of respecting this idea of niggles. I mean, the thing is with elite sporters, they've all got niggles. So this idea of having these constant, dialogue with your athletes and touch points, and that might look like, wellness or monitoring in different organizations. That might be, how our conversations sort of align after, training, after games, after a whole range of different, aspects, I guess, of the sort of the weekly business. But yeah, how do all these touch points sort of feed into how the athlete is responding to said training load and game loads? So I think that's a really big piece, and because as Adam sort of alluded to, within the literature, it's a really challenging space. But then that sort of feeds out into the kind of the sequelae. So is there a lumbar component? Is there complaints around anterior hip tightness, abdominal groin? Is there a groin history? How's that affecting some of their swing phase mechanics? Is there an ankle, is there a recent ankle, niggle that's feeding up the chain from a stance-based kind of aspect of the mechanics and part of some of their extensor kind of mechanism? So it's kind of trying to, like, I guess, put all these pieces together and kind of feed in. Obviously, we're leading all the theories here to hamstring based injuries, but that sort of, obviously that has a fallout effect in lots of different spaces. But as Adam kind of also alluded to, is like those with a past history, those things sort of flash in the back of your mind when these things pop up from a monitoring, a conversation, a sort of touch point of view. So obviously, yeah, some athletes are more resilient, and others that have had that sort of past history may be more susceptible. So sort of kind of really listening out, but then sort of looking to explore from a secondary kind of injury prevention perspective, and then look, when necessary, intervening and modifying. So that's kind of, I would suggest, sort of our primary kind of approach in that kind of subjective space. Yeah.
So I suppose going down that rabbit hole of differential diagnosis before we move on to objective assessments, you've spoken about clearing the joints above, being the lumbar spine, and considering the kinematics from the ankle. What do you find are the most common differential diagnoses when someone does present with hamstring pain? And are there perhaps one or two clues that really help you separate true hamstring strain from other pathologies?
Yeah, no, I think it probably touches on some of the things that we've kind of discussed, and that's where it's really difficult around kind of as and when to use imaging, and I think there will be 100% players that we see who, again, maybe aren't even reporting things or are reporting low-level symptoms that will have some element of injury to an extent if you were to image them. But again, I think it's about what, again, athletes are very good at coping. They find strategies to cope with things, and whether that be their demands in training, they find ways to kind of not cheat but adapt and get through sessions and be able to self-manage. So I think that's where it is very difficult to kind of really truly differentially diagnose between something that's structural, something that's not structural. And again, I think it's more about the pattern of it. We know the big high grade ones. We'd like to think we're not going to miss them. They're going to have those big mechanisms, classic patterns, but it's more the subtle ones that I think are the real challenge for us in terms of kind of differentially diagnosing the grade zeros and the grade ones and those sorts of things. So I definitely think that's where it's the real challenge. I think more than thinking, okay, am I going to miss a hamstring injury? It's more what level of the injury and what exactly is involved within that.
Yeah, I completely agree, Adam. I think that kind of the idea of the grade half, grade one, like that's the most challenging sort of area, because a lot of these athletes we know will present with some hamstring tightness or soreness that won't go on to have a more significant injury, will continue to play, train, and effectively survive, and then we'll have others that niggle is really something that is probably suggesting us some sort of subcellular like failure point that we're just not able to either discern from our clinical markers, from our clinical testing point of view, our subjective components, and particularly MRI imaging in that space as well. So, it's a really complex kind of sort of area, and it kind of keeps coming back to the testing element is just not precise enough in many of those cases. So it's a really hard space. But I mean, just the only other thing I have is that there's this idea of the neural, like the differential element is clearly that we've sort of touched on that, but the prox hemi tendon sort of components. And I speak for I think a lot of maybe clinicians especially within clinics and working at different sort of local clubs that can present in a variety of different ways as well. So just being cognizant, I guess, of that, masquerading obviously as these niggling posterior thigh pain. Obviously, there's it's clearly going to have that proximal component, but sort of having an understanding how that may inform your ongoing management, I guess, of that athlete as well. But it's certainly just something to consider in these cases.
Absolutely. And then presumably you're considering the language used. And do you notice consistency in terms of the descriptors people use, burning versus lancinating versus ache, dull, those sorts of things for your tendinopathies versus your hamstring strains versus your lumbar referrals? And does that help?
I mean, that the hamstring strain ones are kind of like, I mean, as Adam alluded to, the big ones kind of show themselves pretty clearly. They're kind of hard to miss. It is the as I said, the lower grade ones that they will present with. Often the player will describe either, which is, this is the horrible word, but they always say they've got DOMS. They've got DOMS immediately after training sessions, which is unlikely. In terms of how that actually would work out. Tightness is often the descriptors will tend to see. If we are seeing lancinating, burning, these types of descriptors, well, already I'm starting to suggest that maybe there's another sort of aspect to what is driving these symptoms, which might lead me along with, as I said, some of the slump, the passive straight leg raise, and some of our sort of other neural dynamic sort of testing approaches to try and clear some of those features. But sort of the big ones are pretty clear cut. I think they're sort of hard to miss.
Absolutely. So moving on to then the objective component. Objectively, do you have any tests that are your non-negotiables?
Yeah, so I think looking at kind of from my point of view would be looking to kind of understand strength, because I think, like I say, they're good at being able to adapt and show different ways. So I think always kind of trying to quantify and objectify those strength markers. Again, within our setting, we're going to be very fortunate to have a lot of historical data, so we're going to be able to compare that and really understand, is that their norm? And I think if you had someone walking into a clinic, that's going to be difficult to do. You don't know their norms, you don't know where they're able to produce it in. Again, as Scott's touched on, the different ranges and the different lengths, the different contraction types. But I think one of the other big tests for me, as a kind of non-negotiable, if someone can't perform that kind of Askling's H test, that real quick, rapid active straight leg raise, essentially, I find that as a really good marker, because it's an objective marker, but also very subjective. It's trying to see how comfortable that player is, and they can't cheat that. They can maybe find different certain positions in a strength test to bias a slightly more medially if they want to stay away from that kind of lateral hamstring, and just find slight little ways. But if you set up the Asking H test properly, with the straps and everything like that, and you're looking to get them to perform that test rapidly, they should show a lack of comfort or a lack of willingness around that. So again, if someone's come in, as we've talked about, they've got those kind of DOMS-like symptoms that they're reporting subjectively, and we just quickly want to test that. If they're unable to perform that objective test because of a lack of kind of subjective willingness to do it, that would be a real red flag for me, thinking, okay, if they can't perform this bed-based test, then I'm not comfortable with them then going out and looking to perform something maximally in a functional setting, because they've shown a lack of willingness in an isolated environment, and probably not going to be comfortable with them carrying that then out onto the pitch.
That's great, Adam. I think my only add-ons is that I tend to lean on sort of a lot of the Aspetar work, and particularly Rod Whiteley's paper around some of the clinical exam stuff, and mainly focusing on the sort of the combination of palpatory soreness, that MH fake, discrepancy, particularly in length there. I think it's a key feature. I think when I'm seeing a subjective reporting of posterior thigh bone acutely palpatory soreness, and then a loss of MH fake, then combined with a series of sort of bridge testing, and that may include sort of these really outer range based testing, which again we can measure from a strength point of view, from a load cell or a dynamometry point of view. Combining those pieces together, generally you can I think you can elucidate kind of the location of that failure point if you are gonna find it. And Adam sort of alluded to the ones that sort of clear those sort of period, those sort of testing battery, and they're kind of like still presenting pretty well. That's when you kind of do need to elicit I think something that's more demanding from a velocity point of view, as he alluded to. So I think, and then you're going to feel a little bit more comfortable about testing them on field, based off that as well, because I think that's sort of obviously going to be part of the process as well, to make sure that you feel really confident. But if they're not clearing a lot of those other basic tests, I'm starting to have a pretty high degree of concern. And I do think that's people ask me a little bit about this with the aponeurosis involvement. I think when you are seeing a pretty notable failure points, some of those aponeurotic injuries, particularly the longitudinal splits, sometimes can present quite well strength wise, but they tend to still be quite poor from a length perspective. And And so I think if I'm seeing a big deficit there, especially, as I said, coupled with maybe, video footage, mechanistic, understand, like when you're starting to put together all the pieces, in isolation, it gets really strange, especially if the athlete's like, well, I can't recall an incident in that case. So it's again not so clear cut, but it's that's sort of, I think, a pretty kind of a rigorous approach that would look to capture more than you miss.
It would be boring if it was too straightforward, wouldn't it?
Absolutely.
Thank you both. So the last point here is I'd love to talk about what I'm sure everyone's also wanting to know, which is around rehab. So I'm curious, what are both of your processes in terms of early to mid and late stage rehab, understanding that, as we've already spoken about, the diagnosis obviously will dictate and change the prognosis, but are there any consistencies across your rehab protocols?
So I can start. So I think for me, I'm kind of quite a criteria driven kind of therapist, really. So there'd be a lot of consistencies through the different stages, again, almost showing why we're looking to achieve things. But I think in that early phase, again, as has been touched on, a lot of the early ones are trying to get them asymptomatic, because again, I think we have an understanding that the longer that they are symptomatic on things like pain on walking, loss of range on that MH fake, palpable tenderness, the longer that is kind of there, ultimately the longer we're expecting them to miss. So that's going to be a big kind of form the early part of the criteria. Is we can't progress into anything kind of meaningful loading wise and kind of how that looks in terms of rehab until we've got these early signs and symptoms kind of under control. So setting a number on them and kind of going, okay, we need to get that palpable tenderness down to 2 or less out of 10 and make sure that's not reactive as well, kind of monitoring that day to day, making sure we've not had a kind of an acute or a delayed reaction to the loading that we've got. So kind of using that in the early phases. And again, looking to progress through those criteria from a strength-based marker and looking to progress, seeing how they go and going, okay, we might be able to look to kind of get you outside jogging, low-level jogging early doors when you're at 70-75% of your opposite side or your pre-season screening markers, because we understand that we're not actually going to be using the muscle that much at lower level jogging speeds. Within that, we want to encourage kind of functional patterns, getting the muscle being fired in the way. Again, I think there's so much really good work coming out at the moment to show how individualized everything is, and the way that people react is so individual. All our exercises are going to have completely the same exercise, is going to have a completely different outcome in all the different athletes we work with. And ultimately, the sooner we can get them functional and running or moving in the way that they move, will get that muscle firing in the way that they need it to fire. So trying to get that kind of rehab process as functional as possible, as early as possible, but as safely as possible is what I would look to do. And then use those kind of gym-based, bed-based criteria, as touched on, such as things like H-test to give us confidence to progress through with the function. And then probably last point from me on this is around again, going back to the imaging, that fine balance between, again, some of the stuff that's coming out from the guys in Barcelona and Carlos around like re-imaging classifications and how healing stages and try and use those to, again, give us confidence or understanding, looking at levels of edema within there. Has that changed? And we're hoping that edema's kind of going away and regressing as we're progressing through the rehab, but ultimately using that and going, okay, there's been an increase in edema through this stage. We just need to back off at this point and use that as a criteria to understand, is the muscle under stress again? Are we providing too much load too early? And using those kind of healing classifications again to guide us through. But it is a challenge, because that's bringing in so much information into the rehab and trying not to let just one thing guide you. And again, trying to make that bigger picture of, okay, subjectively, we're getting this information, objectively from imaging, we're getting this, objectively in the gym, we're getting this, objectively outside, we're getting this information, and where does that put them at throughout those different phases and stages to progress through.
Fantastic summary. Scott, anything to add there?
No, that was great, Adam. I think completely agree with everything Adam's mentioned there. I really like, obviously, I really like that the idea of thinking of it like almost like an imaging kind of like approach like that. This sort of clinical kind of testing approach, a strength testing approach, like maybe a morphology, like architecture kind of approach, like all those are feeding in across kind of those periods of the rehab Adam's alluded to. Like you have that kind of protective earlier phase. Clearly your clinical, markers sort of inform that in terms of, as Adam alluded to, like when are you recovering from certain elements of, palpatory soreness? Are you able to clear it? It might be a simple, trunk flexion test. Can you pain-free bike, pain-free walk, pain-free run, and you're clearing those. And in my mind, it's in the back of, I guess, my mind, I'm thinking, what is the tissue doing in those early stages? Where are we sitting from a tissue healing perspective? Again, imaging can help inform and support either. Am I right in my decision making there? Is that sort of going to inform when I may use a bit more of a strain based approach? And I kind of probably sit more that side, like when am I going to explore more strain and on the tissues that have failed? So can I protect them early? Can I progressively load them? And I'll use, again, imaging to help support that, but also obviously a range of sort of exercise selection to again either protect, progressively restore, and then times exceed and try and achieve adaptation at these tissue sites. And you're trying to do that across the the phase of the rehab, and trying to align all those pieces is kind of the real fun and art of it. Is like, when do I intervene, in terms of an RDL based approach, which I think we hope to put some work out pretty shortly to try and illustrate some of sort of the demands that the MTU is undergoing in some of these sort of high degree of trunk sort of hip flexion tasks, as well as what does that look like when we're looking at some of our more knee dominant based approaches, and kind of what is the MTU strain looking like that? What is the muscle forces that they're undergoing in these spaces, and how does that kind of look to inform when we intervene? And then we coming all the way back to the start, it's kind of like the peak demands element, like when are we layering on our acceleration demands? We know from a strain rate point of view that can be really demanding. So maybe some of the constant sort of speed running in terms of velocity is probably where we tend to start with, and then try and explore that a little bit later. And that's obviously going to replicate a lot of sporting pursuits, not just European or round ball football and Aussie rules. So trying to just overlay all those pieces of the puzzle. I guess the only things that I tend to lean on with that is a lot of the muscle morphology elements, and sort of utilizing some different technologies. Springbok Analytics has been really big in this space. I think that really helps to inform the type of athlete I'm working with in terms of maybe where they have preferential adaptation. So that might actually look to shift my approach from what they've actually been doing to where I think they need to trend, and sort of layering on some of the muscle architecture stuff. So looking at some fascial length, pronation angle changes. Is my also exercise having the effect that I think it is? That's the other piece of the puzzle, because there's some great protocols and there is great guidelines out there. It's there for everyone to see and utilize. But the challenge is that individual piece that Adam mentioned is, did this athlete actually adapt in the manner that I suspected they would? And then that kind of flips all the way back around to the imaging approach. And am I seeing the adaptation at that, that tendinous lesion? Adam's point around the edematous, like, recovery, But then we've also seen some great work from them showing that from the work from the guys from Carlos and that the sort of Barcelona imaging sort of team, that tendon and aponeurosis will actually have some significant adaptation. They've identified at least some key time points. Now, we know that probably differs for the type of lesion and the type of athlete, but that does give us an idea of, well, is that a more mature based lesion? So therefore I can explore a little bit more from an intensity point of view that might look like, maximal velocity sprinting or the type of task that we're completing in the gym. So yeah, I mean, you can hear that this is the exciting piece of the job and the pieces that we still, where it really is kind of the art form. We're clearly using science to inform us really dramatically, but when we're working with the athlete in front of us, it is, you've got to make a decision, on that intervention. And so I think trying to utilize strategies to at least trying to, review your work. You're kind of constantly doing little pre-test, post-test sort of analyses on a variety of these different levels that I've sort of mentioned. So I think, that's sort of, kind of my approach to it.
That's so I feel like, to summarize both of your approaches, just this magical combination of beginning with the end in mind, understanding the athlete, understanding the sport, the physiology, the muscle morphology, knowing your asterisk signs, and the why to drive your rehab pathway. Hopefully I haven't missed anything there.
No, I think the
No,
beginning
that sounds good.
the beginning with the end in mind is such a great way to place it. I think of the peak demands, and I tend to use that terminology more and more. Now, I think there still used to be worst case scenario, which seems like sort of a little negative. But that idea of, preparing your athlete for all the aspects that they need to do, and that can include many factors. But
Absolutely. Well, Scott and Adam, thank you both so much for sharing your insights on all things hamstring today. I think there's a ton in there for clinicians to reflect on, from sharpening up our diagnoses to differential thinking, right through to the rehab and what that looks like as the research morphs as well. So thank you very much both for your time.
Thanks very much for having us. It's been great to chat to you both.
Yeah, thanks, Sarah. It's a great conversation. Always happy to chat hamstrings.
Fabulous. Thanks, Adam. Thanks, Scott.